Thanks, Tom. So when I was leaving Louisville, my dean, who is a Yale alum, did medical school here, said to me, "Anise, Yale is a national treasure filled with drop-dead, brilliant people." It's true. It's a direct quote. And as with so many things that my dean had told me, he was spot on accurate.
We do have John Morrow.
There you go.
Is that the dead part or what?
Drop dead brilliant.
Unfortunately, I am not brilliant. I am, as my mother would tell you, just a surgeon. So for those expecting, complicated molecular pathways and cell signaling and genomic sequences and mouse models, sorry to disappoint. But I am very grateful for the opportunity to present Grand Rounds and to introduce myself to those of you who I haven't met and to open the door to collaborations because it is only with the collaboration between drop-dead brilliant people and non-brilliant people that I can actually look half decent. So I'm going to tell you a little bit about some of the work that we've done looking at the axilla. Some of this work was funded by an R21, and others have to do with 2 clinical trials that were funded by Veridex. So breast cancer has come a long way. It was only 40 years ago that this was the standard operation that was used to treat women with breast cancer. A Halsted radical mastectomy. The breast was removed along with both of the major pectoral muscles, all of the axillary lymph nodes, and patients were left with a disfiguring, debilitating cosmetic result. And it often was associated with this condition, which is called lymphedema, swelling of the arm, which was also debilitating for many women and often associated with recurrent infections. Well, it was about 30 years ago or so that Bernie Fisher and colleagues at the NSABP started thinking about that. Was it really necessary to remove all of the lymph nodes? Did it really make a difference if we remove the muscle? And so they enrolled patients into a clinical trial where they randomized them to either receive the traditional Halsted radical mastectomy or a total mastectomy where only the breast was removed. These data are now mature, out to 25 years, published in the New England Journal, side by side with a similar study, the Milan 1, which was published by Umberto Veronese and colleagues from Milan. And what you can see, both in terms of overall survival and disease-free survival, is that women with negative nodes do better than women with positive nodes in both sets. However, how you treated the axilla, whether you removed all of the lymph nodes or you left them all behind, made no difference. These lines are superimposable. And so, why do we remove lymph nodes? If it makes no difference to survival, why bother even looking at lymph nodes? Well, we continue to look at lymph nodes for 2 main reasons. The first is staging. Staging so that we know whether your lymph nodes are positive or negative, because clearly that impacts prognosis and will dictate adjuvant therapy. The second reason is for local control. If there is disease in the axilla, we want to remove that disease because if you leave that disease behind, it can recur, which is no fun for the patient and certainly no fun for the surgeon who has to go in there and take out disease that is now encasing the brachial plexus and the axillary vessels, and oh, by the way, the patient still wants to maintain function of their arm. But wouldn't it be grand if we didn't have to remove all of the lymph nodes just to know whether or not the lymph nodes had cancer? Wouldn't it be grand if we could kind of predict whether a patient was going to have positive lymph nodes and only take out those remaining lymph nodes if there was cancer in those lymph nodes? Well, that was a novel concept that Armando Giuliano brought to the world of breast cancer only in 1994, so not that long ago. And the way that this technique works is that we inject a radioactive tracer and a blue dye into the breast, and that tracks to the first draining lymph nodes. We take these lymph nodes out and we send them to our friendly neighborhood pathologist right in the operating room. They cut the lymph nodes in half and say, cancer or no cancer. If there's cancer in those lymph nodes, well then we'll take out the remaining lymph nodes knowing that a proportion of those patients are going to have positive lymph nodes that remain. If, however, those first draining lymph nodes don't have cancer, then the likelihood of cancer in the remaining lymph nodes is very low, and we can spare those patients an axillary lymph node dissection and therefore spare them the potential complication of lymphedema. Well, does this work? A number of studies, and these are all large cohort studies, looked at this and have found that we're very accurate in finding the sentinel lymph node. We can find it in 93% of cases, and only in about 8% of cases are we wrong. In other words, the sentinel node is negative, but there remains disease in the axilla. And these are data, this large study here is from Kelly McMasters, my former chair, which is where the majority of this data comes from. Well, there were a number of people who looked at all of these large cohort studies and said, yes, but you know, we really need a randomized controlled trial because that is, of course, the golden ring. And these are data that David Craig presented at ASCO earlier this summer. And these data were touted as being practice-changing. This trial essentially worked like this. We took patients with a sentinel lymph node biopsy and randomized them to either receive an axillary lymph node dissection as routine or an axillary lymph node dissection if only the sentinel node was positive. So really, the trial only gives us information in the sentinel node negative population. And it shouldn't be surprising to any of you that there was no difference in overall survival. Why is that? Because we know from NSABP B04 that removing lymph nodes doesn't impact survival. And it shouldn't be all that surprising that there were a few more axillary recurrences in the sentinel node only group because we know that sentinel node biopsy is associated with a false negative rate. And so while these data were touted as being practice changing, many of us had already adopted the technique of sentinel node biopsy with follow-up axillary node dissection in the axillary node positive patients and not in the sentinel node negative patients. And so for me, these data only supported what I was already doing. The real question is, how often in those sentinel node positive patients will there be remaining disease in the axilla? And again, a number of studies have looked at this. This is our study from the Louisville group where we had 1,253 patients in a multi-center study who had a positive sentinel node, and of these, 63.1%, so the majority of patients, will have no further disease in the axilla. Well, wouldn't it be grand if I knew who those 63.1% are? Because this means that I am doing an axillary node dissection on 63.1% of patients that could avoid that operation and could avoid lymphedema. Well, maybe we don't need to do an axillary node dissection in those patients. Maybe we can treat them with radiation, or maybe we can just observe. There are 3 large randomized controlled trials that are looking at this. We'll talk a little bit more about the ACOSOG Z11 trial, which is the American attempt to answer this important question. The International Breast Cancer Study Group 2310 and the EORTC AMAROS trial, which is axillary mapping after radiation or surgery, are accruing very well in Europe, and I am looking forward to those results. ACOSOG Z11 was powered as a non-inferiority trial with a target accrual of 1,900 patients. Unfortunately, however, it closed due to poor accrual, accruing only 891 patients, so 46% of the target accrual for a non-inferiority study. Not surprisingly, 27.4% of the patients in this axillary node dissection group had non-sentinel node metastases. Well, we kind of figured that it was going to be in that 30% ballpark based on large cohort studies that had gone before. And if you look at this trial, all of these patients had sentinel node biopsies that had minimal disease in the sentinel node. So all of these were micrometastases and were randomized to axillary node dissection versus radiation. Again, it's not surprising to me, or it should not be surprising to any of you, that there really wasn't a difference in terms of overall survival. Why? Because removing axillary lymph nodes doesn't impact survival. We've known that for 25 years. There was, however, a slight difference in lymph node recurrence rates, and if you look at this number compared to that number, that's twice that. Now, many people look at these data and say, yeah, but that's a really small number, Anise. I mean, is there really a difference between the radiation group and the surgery group? And my answer is, you really can't tell based on this study that is underpowered as a non-inferiority trial, and therefore I am waiting for the Amorous trial, which will answer this question. In the meantime, however, standard of care remains to perform an axillary node dissection, although this data as well was touted as being practice-changing. So I'm also the breast surgery editor for a little publication called Up to Date. And I remember after these data came out, the editor called me up in a panic saying, oh my gosh, we have to change what we wrote about sentinel node management. And she subsequently settled down when she realized that this was an underpowered study. But it does leave us still with a clinical dilemma. What do I do with that sentinel node biopsy positive patient? I'm standing in the operating room. I've taken out the sentinel node. I've sent it to my pathologist, and he says there's cancer. Routinely, I follow this pathway, and I do an axillary node dissection, but afterwards, if all of the remaining lymph nodes are negative and the patient ends up with lymphedema, I feel really, really rotten. On the other hand, if I were not to do an axillary node dissection and the patient would go on to get an axillary recurrence, I would also feel really, really rotten. So what do you do? Well, if only there was a way to predict who could benefit, who would likely have those non-sentinel node metastases, that would help me out a lot. And there have been a number of people who have tried to predict non-sentinel node metastases, from our colleagues not so far away, from our colleagues on the other side of the country, and from our colleagues on the other side of the pond. And what you can see is all of these use similar prediction variables to help us understand who might have non-sentinel node metastases. But for the majority of them, they either use lymphovascular invasion or size of sentinel node metastases, which makes sense, some sort of variable that's going to give us an idea of how much burden there is in the lymphatics. The problem? We don't have these data when I'm standing in the operating room trying to make this decision. So what did we do? We tried to design a prediction model that would only look at preoperative and intraoperative factors. And we made it a simple integer-based point model because, as I told you in the beginning, I'm just a surgeon. So it had to be something that was fairly simple that I could calculate in my head. And so we came up with this based on a multivariate model. If a patient had more than one sentinel node positive, they got a point. If more than 50% of all of the sentinel nodes I took out were positive, they got a point. And if based on tumor size category, they got up to 4 points for a total of up to 6 points. And what we found was that patients who had a low point value, or 1 point, that is to say patients who had tumors less than 5 millimeters, in whom only one sentinel node was positive and I took out at least 3, had a very low chance of having any other non-sentinel nodes that were positive. And so perhaps in that population, I could leave them alone without doing an axillary node dissection. Clearly, this isn't the greatest prediction in the world, but then again, I only had minimal factors preoperatively and intraoperatively to base this model on. Well, has this been validated? Yes, we went on and validated it here in the US. Again, a very small population of patients will have 1 point, but these patients can be predicted not to have any further disease in the axilla. These data have also been validated by Czerny in Europe. And so similar results, a very small population that we can define as having a low risk of non-sentinel node metastases. But how can I make this model more robust? Well, at about the same time, we were involved in 2 randomized trials. And these were multi-center trials that were going on that were funded by Veridex to look at a novel intraoperative quantitative RT-PCR-based assay looking at mammoglobin and CK19. And what we wanted to do was to define a cutoff point that would correlate with micrometastases. So the cycle time for this RT-PCR reaction correlates with disease burden. It correlates with the number of cancer cells in these lymph nodes. RT-PCR is very sensitive, and so we wanted to come up with a cutoff value that would correlate with the yes-no answer that your pathologist would give you, cancer or no cancer. But what was interesting to me was not the cutoff. What was interesting to me was now I had a way, intraoperatively, to have a quantitative analysis of how much tumor burden was in the lymph nodes. Well, could I use this quantitative data to build it into my clinical prediction model? Well, as it turns out, I could, and I did, and we came up with a BLM score using both mammoglobin and CK19 cycle times, and we can see in these multivariate models that stepwise we've improved our prediction ability by adding in this BLM score. And so we came up with these smooth curves that were presented at San Antonio last year. And what we found was, while the clinical values, the proportion of sentinel nodes that were positive and the tumor size clearly predicted non-sentinel node metastases, so did the BLM score. And so even in patients who had large tumors or in whom there was more than 50% of their lymph nodes that were positive, if they had a very low BLM score, they still had a low risk of having non-sentinel node metastases. Well, I was so very excited about these results, and after the presentation, people came up to me, and this was all grand, and what were we doing from here, and what was our next grant going to be, and how were we going to take this forward? And I came home, and I picked up my phone and checked my voicemail, and I got a message saying that Veridex was pulling the assay from the worldwide market because no one was interested in the yes-no answer. And I went, well, duh. But as Randy Posh says, you can't control the hand that you're dealt, only the way that you play it. And so then I moved to Yale. So what am I doing now? So we no longer have this assay. So what can we use as a surrogate? Well, we have gene search, which tells us about circulating tumor cells. Well, maybe circulating tumor cells in the systemic circulation can give me an idea about disease burden in lymphatics, and maybe we can use that as a surrogate and build that into a clinical prediction model. Maybe I can work with Dave Rim, hint, and look at quantitative primary tumor data and see if that can build in to a clinical prediction model. And then maybe we can look at it on the other side and see whether we can predict lymphedema development. So we've started a grant that we put in to look at a number of risk factors for the development of lymphedema. So maybe if we can have a prediction model for lymphedema and a side-by-side prediction of axillary recurrence, then we can help to inform patient decision-making and involve them in that process. So that's where I am now. That gives you a bit of an introduction to me and to what I've been doing here. I hope that that opens the door to future collaborations. With that, I'm happy to take any further questions that you might have.